Hi, I'm Dr. Sharon Obadia. I'm a general internist and director of faculty development at A.T. Still University School of Osteopathic Medicine in Arizona. And we are on video 6, and we're talking about the physician-student relationship. So, I have a medical with me for the entire month on my clerkship, and I'm on day 10 with that student. Suddenly, I'm in a bind. I need to go away for a weekend conference, and our dog sitter just canceled, and I have 2 golden retriever puppies. They're so cute, but they are a little bit of a handful. Can I ask the medical student? This is a great student, very, very responsible, very smart. Can I ask the student on the month to watch the dogs over the weekend? You know, I feel like I can. The student doesn't have a lot going on that month. I know they're studying every weekend, every night. They don't really have a social life, so it's actually the perfect person to have some puppies with them while they're studying. It seems so like such a great idea. Can I? You know, I don't know. And so we're going to talk about that. And how about if a student brings a cup of coffee and I say, hey, that coffee looks great. Tomorrow, can you bring me a cup too? And so can I ask the student to bring me coffee or watch my puppies? And so we're going to talk about that relationship and that power dynamic. So when we're talking about maintaining boundaries with students, we want to talk about what is the teacher-student relationship in medical education. And Dr. Peterson in 1992 said it's a trust-based relationship with a person to whom they have a professional obligation. And it goes both ways. And so it's a trust-based relationship for the student and with the attending, and we both have a professional obligation to each other. So the teacher-student relationship in this case is a mentor-mentee relationship. It's also an advisor-advisee relationship. It's an evaluator and evaluatee relationship. So there's a power dynamic here. There's a teacher-student, as we know, but it's also future colleagues, and I think that's where a gray area can come in with this. And so when these are our future colleagues, we do want to have that level of familiarity with them and camaraderie, and sometimes that's where the gray areas for these physician-student boundaries come into play. So potential pitfalls with the physician-student relationship. Belittling. So like I was saying in a previous video, humor can often be in a sarcastic or belittling manner that we think is we're kidding, and the student takes it crushingly to heart. And so, or favoring. So always asking this medical student all the questions or letting this medical student on the service do all the procedures. And the students notice that. And that pretty much goes in line with discriminating as well. Overt sexual harassment, and we know that what that is. And then asking students for personal favors. Other potential pitfalls are excessive closeness and disclosure. So sharing of personal, professional problems with a student. So imagine if you're in your practice and your practice on the side here, you've been going through a practice dissolution. You and your partner have decided to break down the practice, and it's getting very contentious. And that month, the student happens to be there, and then you start to kind of divulge too much or unload on the student these problems that you're having professionally in your practice. Or personal problems. Maybe you're going through a divorce and the student is there with you the entire month, and it's very easy. You've got a lot of time together to get into personal conversations, and this is somebody who seems very eager to listen. They look up to you, and so being careful to not share personal problems with students or disclose too much personal information. Imposing your own personal beliefs and values onto a student and making the student feel that they don't have a choice but to follow in suit with you. Serving as the student's healthcare provider, this one can come up pretty often because it's very easy. The student is on your service and they say, oh, I have an earache, and you say, oh, let me take a look. And then you see it's an otitis media, and it's so easy to write a script and have the student go get that and filled, and then they don't miss your clerkship days. But I would say hesitate to do that because that's putting the student in now a patient role, and it's crossing the boundary between the student and patient role. So being really careful and cognizant about that is important. Involvement in a student's personal social dynamics is very similar to oversharing your own personal dynamics with the student. It just has the potential to cross many boundaries. And dating and sexual relations, I think that speaks for itself with a physician-student relationship. And if you and your student ever have to talk through that, you can also describe how it's very similar to the physician-patient relationship and the boundary setting that needs to occur at that. So why are boundaries needed? Why are they needed? And it's basically to protect you and the student. And so because it is a trust-based relationship with an unequal distribution of power, we as the attendings have that power and the student does not. And so with the puppies, the student just may not be able to say no to you. If you ask him or her to watch your puppies over the weekend, they may feel it may reflect poorly in their evaluation. Subliminally, you may not even think that you would ever do that. I wouldn't grade a student based on because they didn't watch my puppies, but subliminally it could come into the evaluation, and the student knows that, and the student is afraid that if they don't say yes that to any request that you may have, whether it's getting coffee, watching puppies, anything, that they are not able to say no, and that's where that unequal distribution of power makes it a problem. A physician-teacher can have a coercive influence, and as I said, most often without us any intention or awareness of doing it. Ethical standards of the profession also demand boundaries with patients, as we said, and it's a similar power structure, and so when we role model boundary setting to our students, we're showing them how we would do that with a patient. So it is a delicate balance with a lot of gray areas. If you want to take a student out to lunch on a rotation, is that okay? Is it okay to take all the students out to dinner, and what if the students are having alcohol? And so there are a lot of gray areas that we always need to just take a step back and reflect on whether or not it is boundary crossing, and it's something we all have to do often when we work with medical students. So it's a careful balance between being caring and having that closeness and availability to these future colleagues when also having that distance objectivity, and I do think it's all about that power structure. If we keep that in mind, it'll keep our boundaries in place. The students has responsibility in this as well. They have a responsibility to behave in a professional manner as a junior colleague. They need to be able to demonstrate integrity and professionalism. They also have the responsibility at their institution to report inappropriate conduct and to know the institutional policies regarding inappropriate conduct. So how can we consistently maintain boundaries with our students? Basically, I think it's a lot of constant role modeling, showing our students how we are with our patients, and if something comes up, to discuss it with the student, why this would be a breach of boundaries because of that power dynamic, and that role modeling just similar to a patient care. Continue openly discussing potential boundary dilemmas with colleagues. If you're not sure what to do, should I take all the students out to dinner? Should I take the student out to lunch? You and your colleagues can discuss it and see what you can come up with regard to the ethical and professionalism aspects of all these gray areas. And also with students, they're very keen to enter this discussion as well. Know your professional and institutional policies. Reflect on your own experiences and actions as often as possible, as we just talked about, and know risk factors for engaging in inappropriate relationships with students. And these are on us, and this is problems in our own relationships that may make us susceptible to wanting to reach out to somebody to talk to who's right there and available. Depression or isolation that we may be experiencing, that we may have more of a tendency to want to have more personal conversations with students or connection with a student. So keeping these things in mind is very, very helpful. When we don't maintain boundaries, there's a very big risk that we'll lose professional credibility with not only students but also with colleagues. There are also potential legal ramifications, and it's an artificial ego inflation. The student wants to be like you. The student wants to please you, and pretty much will do. Would like to help you or do what you need to have done so that they can you can think higher of them, especially when it comes time to filling out that evaluation. It also has potential adverse effects on your own personal life, as you can imagine.